Thank you, everyone, and thank you for staying. I know it's the end of the day, and um, so I'll try to get through this quickly. My presentation is on the project that, as Amanda said, I'm working on, and it's looking at the concept of the physical healthcare navigator, particularly in rural and regional Australia, and testing the comparing peer and care and clinical navigators within 4 different contexts. So I'll just go through the lived experience involvement in the development of this project. To start with, I'd just like to acknowledge the traditional custodians of the lands on which we stand today, the Kaurna people, and pay my respects to elders past, present, and emerging, and extend that respect to all First Nation peoples here today. I'd also like to recognize the individual and collective contributions of those with the lived experience of mental health conditions and distress, and those who love and care for us. These perspectives and insights are essential to shaping services, policies, and programs that truly meet the needs of individuals and communities. So this project actually originated through the development of the 2022 Equally Well Roadmap, which demonstrated a lack of evidence of the efficacy of peer or lived experience navigation as opposed to clinical or nurse-led navigation of the healthcare system. This project aims to address this lack of evidence, bringing it into the realm of consumers and carers' experiences, and address rural and regional workforce issues. So the Mind and Body Care Navigators project is a multi-stage project culminating in a 6-month regional trial, and we're on the cusp of doing that at the moment, comparing the effectiveness of peer workers, carers, and clinicians as navigators to improve access to preventive health care for people with mental health conditions. Why is this important? All day we've been looking at different statistics about the big gap in terms of mortality. These are only some of the statistics illustrating the higher morbidity of those of us with mental health conditions due to physical health issues. As you can see, these numbers are concerning, especially when free screenings and vaccinations can help reduce the mortality rate. Our hope is that this trial will be a game changer in improving access to preventive physical health care for people with mental health conditions, particularly in rural and regional Australia, where there's sparse services and other infrastructure issues can impact on access, leading to avoidable deaths from conditions like cancer, diabetes, and heart disease. Lived experience expertise has been at the heart of this project. This visual demonstrates an image of the project's governance structure and demonstrates how lived experience has been central to the project from the very beginning. So the yellow circle in the middle represents the lived experience leadership team, or the LELT, as we're fondly called. So this structure actually went into the grant, what was part of the grant application to the NHMRC. So co-design and co-production in this project has been dynamic and at times challenging. The focus has been on progress, not perfection. It has been a learning process for both the lived experience leadership team and our partner academic investigators. There have been a number of challenges that have meant that at times it didn't feel like we were being authentic to true co-design principles. These include time. It's been a very tight project timeline of 3 years, so we're coming into the final year now. Budget constraints have also impacted lived experience participation as well, and so in order to sustain and keep lived experience central to this project, we've had to be agile in our approach, for example, reducing the number of remunerated meetings and communicating in other ways to meet the project needs. And logistical issues have also raised limitations, such as staffing changes and coordinating between a large group of people across Australia. And it's not just the lived experience leadership team, but there's also the academic researchers and also our advisors. So it's almost about between 40 to 50 people, I'd say, that are all involved in this project. So keeps me busy. There has been a concerted effort, however, to problem solve and address these challenges as much as possible, and the project's successes demonstrate the collaborative effort between the academic investigators and the LELT to overcome project limitations. Some of these achievements include a shared leadership model that was implemented from the very beginning, and this has allowed diverse lived experience members to lead project stages as chairs and co-chairs and provide expertise crucial to the work of the project. The following slide illustrates this leadership model. So it's a very busy slide, as you can see, but members of the LELT have led each stage of the project, ensuring diversity, distributed leadership, and skill sharing opportunities. And we've been working in partnership with our academic research partners. Other achievement includes the development of an out-of-session work policy, which invites LELT members to undertake work crucial to the project, and there's some of those examples there. So this is outside of scheduled meetings, and if people are interested and have the capacity to do that, we've been able to accommodate that. Also, the recruitment of a lived experience research assistant, and full disclosure, that's me. This supports the transition of lived experience advisors in an advisory group in co-design projects to employment as lived experience researchers, and should be considered as a pathway in other co-production work. And finally, the lived experience leadership team led a change of the project name. We strongly felt that the original project name, Physical Healthcare Navigator, did not reflect the duality of individuals dealing with both mental and physical health challenges, and engaged in a co-design process to change the name to Mind and Body Care Navigators. Ultimately, this project aims to empower individuals in their own choices and decisions regarding physical health. Changing the mortality rate for those of us grappling with mental and physical health conditions will only happen when we make it happen for ourselves. Lived experience expertise should lead the way, as has been modeled through this project, and hopefully will ensure it is embedded within the design of the new model of care and its success. And I'd just like to thank everyone on the project team. That includes Amanda as well. In particular, the LELT, the Lived Experience Leadership Team, our co-leads Russell Roberts and Tim Heffernan for their steady guidance and vision. And if you'd like any more information, please email me. Thank you.